It's a pleasure to have Basky, but I'll hand over to Uma now to properly introduce him and kick off. Thanks.
Yeah, thanks, Rahul. It's a pleasure to introduce Professor Basky Tilaganathan. As we were just chatting, it would have been great to have him in person, but he's a man who wears many hats, and I think he wishes he had 48 hours to a day. But he is the head of Director of Fetal Medicine at St. George's Hospital, and he's also the director of the Tommy's National Center for Maternity Improvement, very academic and a very well-known researcher. I'll hand over to Basky to talk about his work, and over to you, Basky.
Thank you, Mo. It's absolutely a pleasure to be here. And as you said, I'm sorry not to be available to speak directly. I'm just going to confirm that you can see my slides.
Yes, we can see it, but it's not in, yes, we can see it in presentation mode.
In presentation mode now. Super. Okay, so let me get the laser pointer. So I'm pretty sure that the audience are a mixed one between data scientists, mathematicians, statisticians, and perhaps a couple of clinicians. My apologies that this is going to be a mainly clinical talk, but I think this is what you're here for, to see some of the problems we've had in maternity or obstetrics, and perhaps give you some insight into why we have these problems and what the solutions may be in the future, where your help as data scientists and deep learning experts is of absolute priority. As Uma said, I am the clinical director for the Tommy's National Center for Maternity Improvement. It was conceived and started in March of 2020, the month we went into lockdown for COVID in the UK. But within the first 2 years, we went from concept, design, development, CE marking of a software medical device called the Tommy's app. This Tommy's app is for use by women and healthcare practitioners, and it provides clinical risk assessment in pregnancy, as well as clinical decision support, so that the healthcare workers can provide the right care at the right time for the women. The incentive for developing this was that even in the UK, there is huge variation in outcomes for stillbirth, preterm birth, and preeclampsia by plus or minus 20%, depending on where you live, what color your skin is, how rich or poor you are. So despite having equitable care, that variation in care is a testament to the fact that women are not getting the right care at the right time. And that's why we developed this device. The uniqueness of this device, which has just started work now, and is being rolled out into 26 NHS hospitals, each of which deliver 5,000 women, is that the data is stored centrally by the NHS digital arm, and that within 1 or 2 years, we should have 250,000 pregnancies with high quality data matched to outcomes from which we can really start making progress. In order for you to understand what we mean by progress, I'm going to start with first trimester risk assessment. When a woman turns up in pregnancy, she has a risk assessment done to find out whether her pregnancy is high risk or low risk. Wherever you are in the world, except if you're in a Tommy Center, this is done using a checklist system, and primarily because of things like this. This is the preeclampsia related mortality in the United States up to 2017. And you can see that there is a continuous increase. And in fact, now in the US, some of the maternal mortality rates in some of the states is equivalent to low and middle income countries. So despite what we believe to be advanced care being delivered all over the world, and especially in the US, there is no evidence or no sign that we are abating this tidal wave of preeclampsia and certainly the mortality related to it. Part of the reason might be because now in 2023, we are using this 60-year-old unvalidated checklist approach to assess risk in pregnancy. The list on the right-hand side is from the National Institutes of Clinical Excellence in the UK, and this is the risk assessment process. We ask women a series of questions, and on the basis of that, we will tell them at their booking visit, which is usually at 10 weeks of gestation, whether they're high or low risk. The problem with such an approach, first of all, apart from it being 60 years old and unvalidated, is that one in 4 to 1 in 5 women will be told that they're high risk. And it can't be in pregnancy that 25% of women are high risk. Secondly, all of these risk factors, because of the checklist, are treated as equivalent. So we might tell a woman who's just a little bit overweight that she is high risk, just as we might say someone who's on crack cocaine is on high risk. And clearly to you, those two risk factors are not equivalent. Finally, we use arbitrary thresholds for continuous variables. So for example, if you're 39 years old, 11 months, you're okay. But the next day when you turn 40, you suddenly become high risk. And also we ignore the interaction between risk factors. So we might tell this 40-year-old woman she's high risk, but not take into account the fact that she doesn't smoke, she's normal weight, she's had 2 or 3 normally sized babies before, never had preeclampsia, and has no disease comorbidities. She really can't be high risk. What is particularly a problem in this checklist-based approach, which is used in India right now as well, and the rest of the world, is that social deprivation and ethnicity are not included in this checklist. And as you know, during the COVID pandemic, we understood that social deprivation and ethnicity were some of the strongest drivers for health outcomes, not just for COVID, but for other diseases as well. And these are not taken into consideration. And by not taking into consideration, we divide the healthcare inequity that exists. We make it worse. We don't improve it. So actually, we may be doing harm by using this checklist, by not including the strongest drivers of adverse health outcomes. If you don't believe me yet, and I'm sure you do, because as data scientists, you see the value of algorithms over checklists. If you tell a woman that she's high risk and she turns around to you and says, doctor, well, what is my risk? And I say, what do you mean? She said, well, you've told me I'm high risk. So what is my risk? You know, is it 1 in 10, 1 in 20, 1 in 30? Such a checklist-based approach doesn't afford us that ability to produce a risk. So if you go and see your obstetrician in your pregnancy, and he or she tells you you're high risk or low risk on the basis of asking a few questions, you then should turn around to him or her and say, what is my risk, doctor? And when they can't tell you, you say, well, you haven't done a risk assessment. You've just asked me a series of questions, isolated, and this is of an unvalidated nature, and you're unable to accurately assess my risk. For many years in the UK, we avoided tackling this problem of inequity of care because we assumed that there was nothing, no alternative available out there. But in reality, that is not true. This is a study that was conducted in 2016, published in 2020, looking at the comparison of a checklist-based approach against an algorithm that contains the same questions in the checklist, but puts it into a logistic regression model, and includes a few other variables, including maternal blood pressure, the size of the baby, for example, a hormone level, and some ultrasound parameters. And what this study showed in 7 hospitals over a year, so including 35,000 women, is that the sensitivity and specificity were doubled using an algorithm compared to the checklist. So what we did was we halved the false positive rate from 23% to 10%, whilst at the same time here doubling the prediction of preeclampsia or preterm preeclampsia. Here, for example, preeclampsia is a condition of high blood pressure in pregnancy, which is the second commonest killer of women throughout the world. So 40,000 women die each year, let alone the morbidity to the women and the children that this disease causes. So we were able to do 4 times better, halving the false positive rate, doubling sensitivity by using a checklist with very little additional information, as opposed to an algorithm with which is what this study used. So the software device contains this algorithm. The healthcare professional just puts in some additional data, for example, blood pressure, a hormone level, some ultrasound parameters, including the size of the baby. And on the basis of that, it produces a numerical risk. It RAG rates the risk, red, amber, green. So it says high, low, etc. And then produces decision support and context-specific decision support. So it says what should be done right now for this specific woman. So this is personalized care as opposed to equitable care. So offer aspirin and schedule serial scans for this woman. And the woman's view will also tell her that. So she's involved in her care. It'll say your midwife or doctor should talk to you about aspirin and arrange some scans for you. And this is based on randomized trial control evidence published in 2017 in the ASPRE study. So this is evidence-based clinical decision support using a software medical device, which is CE marked and MHRA approved. Now, does this work? Because there's a difference between doing a randomized controlled trial, which has been funded for £12 million, versus getting out there and giving it to women every day, day in, day out. So this was a pragmatic effectiveness study, not a randomized controlled study. So we introduced the algorithm and we did exactly as the algorithm said, which was give aspirin and do serial scans. And for those of you, I'm sure as data scientists, you'll be familiar with interrupted time series analysis. When you do a live experiment like this, because it's not an RCT, in order to correct for temporal confounding, you need to do an interrupted time series analysis. So this was the trend in preterm preeclampsia rate before the introduction of the algorithm. You can see that the preterm preeclampsia rate has a prevalence of about 0.8%, and it was increasing slightly over that 1.5-year period. This is the introduction of the algorithm and a 6-month washout period, because remember, you screen at 10 weeks and the woman has to deliver at 9 months. So there's a gap between introducing and the outcome of the pregnancy. And you can see that after the introduction of the algorithm and the effective care, the decision support, that there was a fall in the rate of preterm preeclampsia here. So a stepwise fall as well as a continuous downward trend, leading to an decrease, 80% relative effect in the reduction of preterm preeclampsia in this population. Not only that, there was improvement in compliance. Women are much more likely to take aspirin if you give them a number and tell you them are high risk versus ask them a few questions and tell them at high risk without any numerical assessment. So we were able to show that the efficacy of the study in the randomized controlled trial was replicable in a clinical, practical, pragmatic clinical situation in a standard NHS hospital. And since we left Europe, and England is now a low and middle income country, so we don't have much money. This was done without extra additional funding or resources. What was really interesting to us was that not only did we effect an 80% reduction in preterm preeclampsia, we also had a 10% reduction in small babies. We had a 37% reduction in overall perinatal death. We had a 72% reduction in perinatal death related to growth restriction or preeclampsia. And most importantly, we managed to do this. This is what is represented in the rest of the country right now and in St. George's before the inception of the algorithm. This is the perinatal death rate in white women, and this is the perinatal death rate in non-white women. And you can see that in the country right now, there is a 3-fold higher perinatal death rate. That means either stillbirth or death within the first week of life, 3 times higher if you're not white in this country. Since the introduction of the algorithm in the 3 years following this introduction, the perinatal death rate in non-white women fell so that it was not significantly different from the white women. This is the only country, the only hospital in the country where if you're not white, you do not have an increased perinatal death rate. So the $64,000 question is, when we introduced a screening test for preterm preeclampsia or preeclampsia, how come we had all of these different improvement beneficial effects and we were able to negate the effect of ethnicity because the algorithm contained ethnicity? The reason for that is obstetricians have had it wrong for a long time, and Uma and Ram may have a go at me for this, but I think you need to understand this algorithm. So obstetricians talk about these disease groups: SGA, smallness or fetal growth restriction. They talk about stillbirth as a disorder, a disease. They talk about preeclampsia as a disease, and they talk about preterm birth. What they do not recognize is the fact that actually being small, dying, having high blood pressure, or being born early are not diseases, they are outcomes. Yes? Whereas the disease is placental dysfunction. The placenta doesn't work properly. If that is the case, it may not give you food and you're small. It may not give you oxygen and you die. It may be that the mother responds to it by improving and increasing heart rate and function and blood pressure in order to overcome the lack of perfusion. And it might be that the right thing that the baby does is to eject itself before it dies, which is preterm birth. The corollary for you to think about is something like brain cancer over here. Brain cancer may result in headache, may result in confusion, may result in dizziness, yes, and photophobia or double vision. All of these things are outcomes. And we are not going to make much progress in detection of brain cancer if we develop screening tests to look at dizziness or double vision, when actually what we're after is brain cancer. If you don't believe me, when we looked in this cohort of 20,000 women and we said, well, if the women were high risk, what happened to them? We found that in the women that were high risk, according to a preeclampsia test, their stillbirth rate was 2%, tenfold higher than the background. Their preterm birth was 12%, threefold higher than the background. Hypertensive disorders of pregnancy occurred 2.5 times more often. Growth restriction occurred 2.5 times more often. And composite-wise, 45% of women who were considered high risk according to a preeclampsia test had adverse outcomes that were attributable to placental dysfunction. So one of the problems we have in obstetrics is that we have created these disease silos, which are not diseases, but outcomes. And that limits our ability to interpret the data that you're provided. So if you are going to involve yourself in a maternity project or an obstetric project, please be aware of this and challenge your obstetrician, 99% of whom still do not understand the distinction between disease and outcome. I'm going to go to the second half of my talk, which is about timing of birth. So in early pregnancy, we can do a risk assessment to decide how we manage the pregnancy. And I want you to think of pregnancy like an airplane journey between Mumbai and London. I want the pilot to be awake at takeoff to get the plane off safely, at which point he can go to sleep, put it on autopilot. And then I want him to make sure that he's wide awake, or he or she is wide awake when you come to land the plane. And the same is true of obstetrics. Pregnancy's most dangerous points are takeoff and landing, the beginning and the end. And timing of birth is absolutely crucial in order to optimize the health of the mother and the baby. Why is that the case? And what do we look for in timing of birth? Well, essentially, size is the key issue of the baby. Whatever way we measure size, whether it's through absolute weight, through centile, through ponderal index, or deviation from the mean, weight is associated with increased perinatal death, between 2 to 10-fold increase in the perinatal death rate. There is no argument that there is an association between being small or not growing properly and dying. And here is an ancient study from 20 years ago that shows you that if we diagnose the fact that the baby's small, the perinatal death remains slow, no matter how bad the growth restriction is. Whereas in undiagnosed cases, the perinatal death and stillbirth rate increases. So being small increases the rate of death, but if you diagnose being small, you can significantly reduce the chance of the baby dying. So that is the basis for the last 30, 40 years of our obsession with looking at the baby's size. But that is the beginning of our problems. The best way to estimate size is to measure the baby. There are about 70 different formulas when you take fetal measurements to calculate estimated fetal weight. What is the weight of the baby according to the measurements you take? Thankfully for us, we now know from systematic studies, the best formula is one by Hadlock, created in 1985, that takes into account the abdominal size, the head size, and the female length. And that gives us a very close estimation of the fetal weight. So that problem has been solved. The problem that we haven't solved is once you know the baby's 2 kilograms, we need to decide how deviant that baby is from the median for gestational age. So these is gestational age in weeks, and this is the median, and then 97th, and the 5th centile here. So you've got to plot it on a population standard or a reference standard to say, okay, well, is the baby on the 50th centile, the 10th centile, or the 5th centile? And therein lies our problems, because if you have a look at charts, this is Europe, for example. These are 15 countries in Europe, and in red represents the 10th centile, and in blue represents the 90th centile of weight in these 15 countries in Europe. These authors published this data and said, well, actually, because the weights of the babies vary greatly in these countries, we can't use an international reference standard. And it's bizarre for 2 reasons. One is the only difference between these countries, and some of them are so close together. For example, Netherlands and Belgium are next door to each other, is that in order for this baby to align itself to one of these charts, it's got to know what passport the mother has. And I pretty much guarantee you the baby doesn't know what passport it has. It doesn't know whether it's got a Norwegian or a Finnish or a Swedish passport. So how does the baby know what chart to use? And how does the baby know how to grow? So it cannot be that the passport or the nationality of the mother determines the size of the baby. What is more curious is that if you look at in one country itself, in Belgium, which is one of the smallest countries in Europe, they have 3 different charts based on whether the mother speaks French, the mother speaks Flemish, or the mother lives in Brussels, which is the capital. So here they say not only the baby knows what passport the mother is using, the baby also knows what language the mother is speaking. And this is clearly absurd. It cannot be that your nationality determines your fetal size. So are we using nationality as a proxy for ethnicity, let's say? And this is important for you as data scientists, because you're going to get data sets with ethnicity and you're going to assume that that's all robust. You know, it's a number or classification, it's got to be correct. But think again about ethnicity. Ethnicity is a social construct. It is not a biological determinant. If you ask women, and this is about classifying their ethnicity, Asian women tend to classify their ethnicity according to language. Hindi, Urdu, Gujarati, etc., according to, or Tamil, according to the language they speak. Chinese women tend to classify their ethnicity according to their physical appearance. And Australians and Europeans classify their ethnicity according to their country of citizenship. Hence the study from Europe looking at the 15 countries as a proxy for ethnicity. Not only that, but for example, ethnicity can be classified according to your religion. Hispanic ethnicity can be classified according to your language. Jewish religion, Hispanic according to your language. In America, they have white, they have black, and they have Hispanic, who are white people who speak Spanish or of Spanish ancestry. So it's really weird, yes, and it cannot be that the 1% of genes that determine the mother's skin color is also paradoxically or coincidentally the genes that determine fetal growth and size, as well as, for example, determining cardiovascular risk, diabetes, and other disease prevalences. So please be aware that ethnicity is a social construct and not a biological determinant. And if you need proof, this is a recent study we published to show the relationship in our population between white, black, Asian, and other ethnicities with socioeconomic deprivation. This is IMD quintiles, index of multiple deprivation. And these are very deprived and the least deprived. And you can see there's an overrepresentation of Black and Asian women in the most deprived groups, whereas in the least deprived groups, there's an overrepresentation of white women and mixed race populations. So not only is there a huge confounding effect between that, but also socioeconomic deprivation. These quintiles are related to the adverse outcomes of pregnancy. How can it be that your education, your income, your health, etc., because these are indicating to you that maternity outcomes are not just a biological impact of the size of the baby, but also the socioeconomic circumstances, the language, access to care, diet, malnutrition, comorbidities, treatments and illnesses and access will all impact on adverse outcomes. So please be aware of that issue. Now, if you ask Dr. Ram, she might argue and say, well, irrespective of what's going on in each country, she believes in the obstetrician's paradigm, which is that only 10% of fetuses can be SGA. That means below the 10th centile in whichever country you are. This is the rate of malnutrition in babies, in neonates at birth throughout the world. And you can see that there is huge variation at birth as to the prevalence of the low ponderal index in the neonate to indicate malnutrition. And it can't be that babies at birth have these variable rates of malnutrition, 20% worldwide, 35% in South Asia, only 8% in Scandinavian countries. And yet before birth, the hours before you go into labor, only 10% are allowed to be small. So that alludes to the fact that what we should be using is an international growth or reference standard, and there are only two. There's the WHO standard and the intergrowth standard to assess baby size. And if indeed in India, when you use the standard, 20% of babies are said to be small, then so be it. And if you use it in England and only 8% of babies are small, so be it, because that is a reflection of whether the babies are growing big or small. In the same way that in India right now, the rates of gestational diabetes are considered to be high because we use an international reference standard to make the diagnosis. We haven't redefined gestational diabetes in India in order to make only 10% of women having gestational diabetes. In the same way, we should not redefine growth of the baby to change that. However, irrespective of how you define the size of the baby and which chart you use, if you look at term, one of the major problems we have is that 70% of babies dying at term, which is from 37 weeks onwards, are not small. They are above the 10th centile. Yes, about half the babies that we lose are lost at term, and 70% of them are above the 10th centile. So they're not small at the time that they die. Why is that? Why is this relationship between size and death not there at term? Well, if you look at it again, there is a relationship, but the relationship is very weak. This is a study looking at babies below the 3rd centile, so extremely small babies, really 1 to 2% of the population. And indeed, there is a risk with adverse perinatal outcome, and indeed, there's a risk of perinatal death. But you can see from these ROC curves that the prediction is quite poor. So for a 10% false positive rate, we would only have about a 25% prediction for perinatal death. That's very poor. We'd miss 3/4 of the deaths. And that's demonstrating exactly what I said, which is that size is a poor predictor, associated with, but a poor predictor of death at term. Why is that? Again, the distinction between symptom and disease. The pathology is the placenta. The symptom may be slow fetal growth because of a lack of food that the placenta gives you, but death and disability, dying of the baby or neurological handicap, is a consequence of hypoxemia. Stillbirth and developmental handicap occur due to hypoxemia and not malnutrition. And so in order to understand that, you've got to understand this graph. This graph shows the nutritional requirements of the fetus as the pregnancy goes along. And this red line shows the oxygen requirements of the fetus as the pregnancy goes along. If the placenta fails early, it has a massive impact on the size of the baby, but the oxygen demands are low, so the baby may survive for several weeks before death. If the placenta fails late in pregnancy, when the nutritional demands have plateaued, but the oxygen demands are increasing dramatically, this baby may die within a few days or a week of the onset of placental failure, at which time the baby doesn't have time to shrink. It's already 3 kilos. It can't shrink within a week or a few days. So babies that die at term die of oxygen deprivation before they can manifest the symptoms of smallness. And that's why smallness is not a good predictor of term stillbirth. So what is the option? The option is that we can assess using ultrasound blood flows to the placenta and brain and look at what's called redistribution. If everyone in the audience were to hold their breath now, the blood would go to the brain, preferentially to your fingertips. And that's your body trying to keep your brain alive. And the same is true of the fetus. Where there is hypoxemia, there is a redistribution, and it's termed CPR, cerebral placental ratio. And that redistribution is a reflection of hypoxemia. In this meta-analysis of 128 studies involving 50,000 pregnancies, you can see here that using CPR for a 10% false positive rate, we're able to get about a 60% prediction of perinatal mortality. So that's 3 times better than size alone. So how do we use it at present? We use it at present in this rather arbitrary fashion, which is when babies are extremely small, because it's so rare and the risks of perinatal death are 5 times higher we deliver. But between the 3rd and the 50th centile, where the most babies are likely to be hypoxemic, we use a Doppler reference. And based on that, we decide whether to reassure or to deliver. And of course, you all realize that this is a rather crude approach to managing pregnancy. It's you categorizing patients. So if you were on the 2.9th centile, you may be delivered, but if you're on the 3.1st centile, you may have a normal CPR and be left alone. And therefore, what we desperately need, in the same way of the algorithm in the first trimester, is an algorithm that integrates maternal characteristics, fetal size, and the Doppler parameters to tell us about risk of adverse outcome. So where are we? We've been using the same care pathways for the last 60 years and hoping that we would improve maternal and fetal and neonatal outcome. And as this guy once said, the definition of insanity is doing the same thing over and over again, but expecting different results. And that's not going to happen. It's not going to happen because obstetricians have not yet cognizant of the distinction between disease, placental dysfunction versus outcomes, preeclampsia, stillbirth, fetal growth restriction, preterm birth. Secondly, the prevalence of disease is fairly low, so stillbirth may occur in 2 or 3 or 4 in 1,000 cases. Thirdly, there are multifactorial causes. If you ask an obstetrician, they would just say, it's all about the placenta. But you and I now know that nutrition, comorbidities, infection, bleeding, anemia, etc., all contribute. And that we must take these all into consideration when trying to assess risk, not just look at the placenta arbitrarily. Intervention bias is a key issue. If you develop a screening test which shows that the baby is going to die next week, and you let the obstetrician know that, they're going to deliver that baby today and prevent the baby from dying next week. And they're going to remove the outcome that justifies or validates your screening test as being effective. So intervention bias is critical here because we've defined these outcomes as diseases. Yes, if you have a prediction test for the baby having Down syndrome and I deliver the woman today, the baby will still have Down syndrome. Intervention bias isn't an issue because we've labeled the disease or the pathology correctly as Down syndrome. If I say the woman's going to develop preeclampsia next week and Dr. Ram delivers the woman this week, she is not going to develop preeclampsia next week. And Dr. Ram might turn around to you and say, your screening test is terrible because it said my woman's going to get preeclampsia and she didn't. And that's because preeclampsia is not a disease, it's an outcome. And by intervening the pregnancy, we've prevented that outcome. So intervention bias has to be taken into consideration in all of your models. And there are time to event competing risk approaches fundamental in your deep learning approach. Big data is crucial. Because of all the things, big data is crucial for our ability to access it. And the Tommy's National Center, by collecting national data progressively and high quality data, is leaning itself towards that approach to absolutely improve the algorithms we currently have using a deep learning approach. If you're interested in the Tommy's Center, there are some QR codes here that you might want to do. This is a very simple explanation. It's just a Q&A to explain the fundamentals or the basics of the Tommy's approach. And this is a little bit more detailed, sort of very crude look at the device and how it works to give you an idea of what it's doing. But behind it is a CE mark device, which is collecting data now from 26 hospitals in the UK and very soon from another 8 hospitals in Australia. We're hoping that somebody massive healthcare institution in India, like the Tata Health, may consider approaching and working with people like us to be able to create a low and middle income country version of this device that can be used in India, let alone Sri Lanka. Thank you very much for your attention.
Thank you very much, Basky. Rahul, over to you to take questions from the floor.
Yes. Any questions from the audience? Yes. Is there a mic?
Yeah. Like you said that you were trying to say that the weight is not a disease, it's an outcome and it should be treated like that. And I think this is something which we as a machine learning engineer would like to know, like how you went on.
I'm sorry, I've just lost you.
Can you hear me now?
To see.
Yeah. Hello?
Hello? Can you hear me?
I can hear you.
Oh, could you repeat your question? I lost you halfway through. I'm so sorry.
Okay. So my question was basically, you said that weight and everything is not a disease, and definitely it's not a disease, an outcome. Like at what level you decide something is a disease and what is an outcome, so that maybe this is something which we can take in different disease area as well.
I think the best thing is, the analogy I used, it's a good question. Okay, so don't, it's not a silly question. really important, because if you talk to an obstetrician right now, they'll tell you that being small is a disease and having preeclampsia is a disease and dying is a disease. Now, if Tata Health were to go out there and give, 100 lakhs to somebody to invent a screening test for dying in the adult population, do you think that we would be successful? We wouldn't. Death as an adult is death. It may occur from a number of reasons. But in obstetrics, we are on the eternal quest for a screening test for stillbirth, which is totally absurd. Yes, because stillbirth is an outcome of hypoxemia of the fetus. In the same way that being small is an outcome of not having nutrition. And being small isn't a problem. Half of India is small at birth, but it doesn't stop you being in this venerable institution and being the leaders of software development in the world. Okay, so being small isn't the issue. So when you are when you get that data set, when you're plundering it to develop algorithms that can be useful to me in daily practice, don't consider preeclampsia, smallness, stillbirth as isolated diseases. You put them together and you say, I want a screening test that's going to detect for me, yes, at one end of the spectrum, the most severe preeclampsia, the smallest baby and the dead baby. And at the other end, you have a more inclusive approach. Yes, you create an algorithm that can detect mild preeclampsia, babies below the 28th centile, et cetera, et cetera. So if you create an algorithm well enough to predict the worst outcomes, then as a clinician, I can choose where I set the threshold in the algorithm, 1 in 50, 1 in 100, 1 in 200, to afford me the ability, given my resources, to look after my population. Yes, so if you create the algorithm based on the big data to say, we're going to look at all of the outcomes because they reflect the disease placental dysfunction, you create the algorithm, and when I use it, I can vary my threshold. If I'm in a very poor country that can only afford scans for 10% of women, I will have a false positive rate of 10%. If I'm in Sweden and I can scan 50% of our women, I will change my threshold and allow me to scan 50% of women. Does that make sense?
Yeah, thanks. It was really nice.
A question to you, because you've got the microphone. Oh, okay. Can I ask you a question back, please?
Yes, please.
Sir?
Yes, please.
Can I ask you a question back? So
go ahead, Basky.
Do you have deep learning approaches that can account for intervention bias? Anyone in the audience?
Anyone want to answer that? People are shaking their heads.
Oh, come on. Someone
experts.
must know out there. I'm a clinician. I just deliver babies for a living. You're a data scientist. Tell me.
Can you repeat the question?
Is there a deep learning approach to account for intervention bias? And is the question, is there a deep learning approach to recognize that there is intervention bias, which is sort of unknown to, I mean, it's mixed up in the data set, and a way to filter it out? Is that the question?
Yeah, that is the question. So intervention bias is treatment paradox. Okay, and you must be familiar with that. And in a conventional approach, what we would do is do what's called a competing risk. So if the woman is delivered today by Dr. Ram, I will truncate the data there to say it might be that this woman may have gone on to have a stillbirth or a preeclampsia, but I don't know because the data is truncated at 36 weeks when Dr. Ram delivered it. Is there an approach for doing that using machine learning, supervised machine or deep learning? Can you have an approach that says, we're going to create a screening test. The screening test may be good, but we're going to account for the fact that birth truncates our ability to predict the adverse outcome. That's the question I'm asking.
So I'll give it to Tav, but also add on, is there anything for selection bias? It sounds kind of similar. Is there any method to automatically recognize selection bias? You have a mic?
Thank you, Basky, for that question. To the best of my understanding, unless these are explicitly accounted for in the model, causal nets can be one example. Deep learning, standard machine learning approaches, to the best of my understanding, will not account for intervention or selection bias where you don't know the generative mechanism of the data. Okay. To the best of my understanding.
Okay, so I think thank you. That's really useful. It's a very solid answer. So I do think that if you get these data sets in maternity, one needs to have some degree of supervision to the deep learning to say, as soon as the baby is delivered, that data is no longer useful. So you need to have that competing risk approach. You need to inject it into that model in some way. I don't know. I'm not an expert and I can't do that for you, but if it doesn't do that intrinsically, then that has to be part of the deep learning approach.
Yeah, go ahead.
Hello. Yes. Professor Basky, I wanted to ask about when you mentioned data sets, what types of data can be collected? So could you please reiterate on that?
The data sets are disparate. I mean, if I were to give you the UK example, right now we have 130 maternity hospitals in the UK. They use 35 different maternity information systems, EPR systems, to collect the data, electronic patient records, 35 different systems in these hospitals. And then all of the data is stored on 110 different servers using 35 different EPR systems. Can you imagine? Yes, and each hospital has maybe 150 individuals entering the data in different ways. It's absolute chaos out there. Even if you were to get all of the data together, the robustness of how that data is filled in and how accurate the data is one issue. The second thing is accessing the outcomes, because the outcomes are not necessarily entered in the way that you and I want it. And having robust data with the correct outcomes is the second problem we have. And I'm pretty sure that that's the same in India and other countries of the world. The exceptions may be in Sweden, where people are paid lots of money to ensure accurate data entry. The Tommy's algorithm is pre-designed not only to provide good care for the women and provide equity of care, it's pre-designed to make sure that it collects the right data. So all of the key data, it only allows you to enter the correct data. So you can't enter the wrong variables, etc. It compartmentalizes you and say, you've got it wrong, please check it again. It enters high quality data, so it has the maternal demographic characteristics, it collects biometric data from ultrasound, it collects biometric data from blood pressure, it collects hormonal data, PAP8, PLGF, etc. It collects all of those data as well. And then it's linked to the maternal information systems to draw out birth and death and preeclampsia and growth restriction. And in case it doesn't link, the mother who is part of the process, she has her own version of the app that she can see, not the medicalized version. She sees a woman-friendly version. If the outcomes aren't filled in around the time of birth, then she gets queried to say, can you please let us know when you delivered, how heavy your baby was, did you have high blood pressure, was your baby alive, etc. So we have a robust process to chase up the outcomes. And you certainly can't have another pregnancy for the same woman until you enter the previous pregnancy outcomes. So by building that into the device, we are able to get high quality antepartum data that is linked to accurate diagnostic and birth data. And that is a rare ask. So yes, beware and be aware of the quality of the data issues.
Anyone else? So I have a question about the nice growth percentiles in European countries graph that you showed. And yeah, Wallonia and Flanders and Belgium are all basically next to each other, but it's kind of stereotypical that the Dutch are tall and the French speakers are not that tall. And in fact, since the Second World War, I think the average height of the Dutch has increased by almost 1 foot, adult Dutch. So two questions are, do you think it is just a question of nutrition standards and so on, which must be pretty good all over there? The proportion of immigrants and the mix of ethnicities must be similar, or is there a genetic component? And a related question is, what is the, as you said, SGA is an outcome and not a disease, but what is the proportion of neonatal complications in these countries? Do the countries where the babies are smaller have a higher proportion? And if so, is there an explanation? If not, should we be even worrying about it?
I think they're two separate and very good questions. The first one is easier to answer. You cannot possibly be suggesting a genetic component related to the passport of the mother. Okay, so you can't say, okay, could the genes explain why the Dutch?
No, it's not about the passport. There are definitely, mothers in Netherlands who have Indian origin and so on, but the majority in these countries have been, the majority of citizens in each of these countries has been living there for generations. So there is.
Okay, so I'll recommend a good book for you to read from Hawaii. Hawaii was one of the first countries to have multi-ethnic populations with good public health and epidemiology outcomes. And what they showed is that there is a generational effect. It takes about 2 to 3 generations before an immigrant from Asia or Africa living in Europe will avail himself or herself of the local characteristics. And unfortunately, in Europe, Indians and Africans have not been there for 2 to 3 generations yet. In the next 2 or 3 generations, the outcomes for Black and Asian women should be indistinguishable from white women, as long as we achieve the inachievable, which is sort out the socioeconomic deprivation, yes, sort out income, sort out educational achievement, sort out access to care, sort out language issues with access to care, and sort out institutional racism. We've got a paper coming out soon in the BMJ that demonstrates actively institutional racism in European countries to people who have Black and Asian skin color. All right. So first of all, in Belgium, for example, the French Wallonians only represent about 15% of the population, and they are far more socioeconomically deprived than the Flemish. So it's well attributed that the socioeconomic deprivation is hugely responsible for the adverse outcomes there. It would be churlish of us to suggest that there's a genetic component which is related to the language and the passport in Europe to attribute for this. So almost certainly it's nutrition, diet, confining, smoking, money, access to care, that's the issue. Nebulous things may affect it. So did you know, for example, if you're in Belgium, healthcare is free? It's not. For every time you go and see your doctor or your hospital, you have to pay 9 euros. Okay, you have to pay 9 euros. 9 euros, 10 pounds. I don't know how many rupees that is. But you, sir, would be able to afford those 9 euros when you go with your wife to have your checkup. Do you think everyone in India would be happy to pay those 9 euros to go and see them? No. Who are the people that are most likely to miss their hospital visits? The rich, affluent, healthy, or the poor who are having 2 jobs? Not only do they have to pay the 9 euros, but if they go to the hospital, they lose the income from the job that they're being paid hourly for. So healthcare inequity in these countries is worse than you can ever imagine. Of course, the health outcomes are better than in Africa or some parts of Asia, but the inequity of care is inexcusable in Europe. That's one question answered, but we can argue about that for hours because ethnicity is an emotional subject. The second question is, does size actually matter? I don't think it matters at all. I was 5 pounds 6 ounces at birth. I'm 6'1" now, and perhaps the hypoxemia has dulled my academic ability, and I could have done a lot more if I had been less hypoxemic in utero. I don't know. So you're right. If you ask parents what matters, they don't care about the size of the baby. In fact, most of them can't remember the size of their baby 10 years later. But what they will care about is whether the baby died, whether it had neurological handicap, or whether I lost my wife because she had preeclampsia or major hemorrhage. So yes, I agree with you that when you look at this data and you use an outcome-based approach, please be sure to choose the outcomes that matter to the parents and not the ones that matter to Uma and myself as obstetricians about whether the baby delivered early or not. A mother won't care if her baby was preterm, if the baby then grows up to go to the All India Institute and be the clinical director. Who cares if my baby was small or born early? Nobody. Sorry about the diatribe.
No, it was, we are here for the, insights. So yeah, that's, I think anybody else, anybody online, Uma, or there's one question here. You go ahead.
Yeah, I have a question.
Yeah, go ahead.
I have a question, if I may. Yeah. So Basky, we got the concept of paying more attention towards the disease rather than the outcomes, because these outcomes are just reflection or symptoms of. But when it comes to clinical research and probably prediction modeling research, we all look for an outcome to model, right? At an operational level, we need an outcome to look for. And that's the operational reason is what forces people, because disease per se, you can't measure, you can't assess, you can say placental dysfunction, but how do you, right? So easiest to do is to do the outcomes. And that's where people, and there is a fundamental pressure on the institutions, funding institutions, to look at pre-eclampsia separately, preterm birth separately, stillbirth separately. There are calls revolving around those things. But do you think, but of late, obstetricians whom we work with are talking about great obstetric syndrome, which kind of covers most of these things. Do you think for an operational purpose, for a clinical researcher or a data scientist, looking at an outcome which is defined as great obstetric syndrome is much better than looking at individual outcomes? Thank you.
Yeah. No, I think you're on point there, Ram. So I think you're giving too much credit to the grant funding organizations that are using these silos with the knowledge that these outcomes are not diseases. Most grant giving bodies don't recognize that. Most obstetricians don't recognize that. If I go to conferences all the time. 99% of obstetricians will tell you that preeclampsia is a disease and fetal growth restriction is another disease, and stillbirth is the bane. Totally different diseases. So one is a learning point. There are two things. One is understanding the disease more, and number two is improving the outcomes. So I think there needs to be greater recognition of the fact that these are outcomes, and the disease are placental dysfunction, and the way into that disease is by having biomarkers, yes, biochemical, biophysical, clinical biomarkers of that disease. And when you create your model, you create your model around the hardest and most robust outcomes. Yes, so don't go for the mother had borderline blood pressure at 9 months, because I have high blood pressure at 9 months when I'm pregnant, because my God, it's just hell. My feet are swollen, my toes are swollen, it's so hot. Who isn't going to have high blood pressure? So go for the preterm preeclampsia. Yes, go for the stillbirth. Don't go for the small baby. Go for the extremely small baby, or the baby that died in utero, or the baby that came out with HIE that needed cooling. If you create your model around the biophysical, yes, so very small or severe Doppler changes, the biochemical, high split PLGF ratio, yes, the clinical, the 45-year-old super obese woman who smokes 500 a day, these are the core characteristics that will help you identify what are for sure placental pathology cases. Now, when you use that model in the real world, of course, you're going to identify those cases. And somebody's going to presume that just because you set the threshold at 1 in 50, that at 1 in 51, everything is okay. No, that is the second problem that obstetricians have. We have this arbitrary categorization of continuous variables. So when you create the model, we then need to teach obstetricians that we need to use the model in a clever, continuous way to personalize care for the women, not to compartmentalize them as good and bad, where the cowboy wearing the white hat and the cowboy wearing the black hat. No, there are 100 shades of gray in between, and the care pathways that we provide these women will vary according to the health institutions and the health resources. Yes, so in Sweden, they may well have different percentages in different compartments that get different pathways, whereas in Sri Lanka, we might just say, okay, we can only afford to do this, so we're just going to go for a 10% false positive rate, and those are where we focus our limited resources on. That's what we can manage. So build the model well, then leave it to the clinicians to say, how are we going to use the model?
Thanks, Basky.
Thanks. There was a question in the front row. Can you ask?
Yeah. Professor Basky, so is there any regional biases will arise out of Tommy's app if it is implemented in India, considering the type of algorithm and features are used for the development of the app?
I didn't quite get your question. You said did you say could there be biases in the use of the app?
Yes. Yeah, outcome of the app.
Yes, there certainly could be biases. So the algorithm was developed, the FMF algorithm was developed in England, where we, from a population that was about 10% Afro-Caribbean, about 20% Asian, and the rest white, with only a few mixed and other ethnicities. Having said that, the algorithm was then externally validated in 3 different cohorts, mainly in England and Europe, but in 16 different hospitals. So the algorithm is transferable. It has been used and it's been externally validated, used in an efficacy study and shown to work in effectiveness trials. So I'm pretty sure it will work okay. The parts that will cause bias are the fact that, as you've understood from me, I don't believe that ethnicity is a biological determinant. I think ethnicity is a marker of socioeconomic deprivation, income, access to healthcare, nutrition, and health comorbidities. What will be different in India is that for the same woman with the same risk, a woman who is more socioeconomically deprived will have a worse outcome than a woman who is less socioeconomically deprived. Now, we will in the UK, using IMD quintiles and deciles, adapt the fetal medicine algorithm in 2 years to improve our ability to predict adverse outcomes in white women who are socioeconomically deprived, because that's not done well at the moment. And in the same way, if you start using the Tommy's algorithm in India, once you have enough data, we'll be able to use postcodes, addresses, yes, all of those criteria to determine adverse outcomes and include that in iterations of the algorithm in the future. So of course there'll be biases to begin with, but the algorithm will be better than what is being done now. And the Tommy's app will give us the data we need to build the algorithms of the future, developed by people like you in the audience.
Thank you.
So I have high expectations of what you will do for me.
Very good. Yeah, you had a question? No, I think we are done here. Ram or Roma, any other comments or questions online?
No, I was just curious, Basky, given, I mean, 2 things. One is, in trying to explore how we could adapt the Tommy's app, what the roadblock, one of the roadblocks that comes about is that both uterine artery Dopplers and biomarkers are not done, and therefore, not done in the larger public hospitals. So we may not be able to use the power of the algorithm in its fullness. So that's, so we may have to adapt it in that sense that, yes.
I anticipated that. And the algorithm, the way it's built into the app is that even here in this developing country we call England, there are such limitations. So not everyone gets PLDF and uterine Dopplers. What happens if you don't, so mandatory, you must put in all the maternal characteristics. Mandatory, you must measure her blood pressure. Mandatory, you must put in a dating because we've got to know how far she is. But if you don't use uterine artery Doppler or a biochemical parameter, what happens is that your false positive rate is higher. So instead of having an 8% false positive rate, you may have a 15 or 20 false positive rate. So you may give more women aspirin and bring back more women for follow-up scans. But you will not, yes, underperform. And in that period, you will then collect IMD data, yes, and be able to then build the algorithm to perform better in India. The roadblock isn't that, because the device is developed in order to be used anywhere you want it to with the minimum basic standards. The roadblock is that it's not a roadblock. The manufacturer of the device is a unique collaboration between the Royal College of Obstetrics and Gynecology and the Royal College of Midwives. So we are the manufacturers of the device. They are not keen to come and give it to a single health institution or a single obstetrician anywhere. So at the moment, we've given it to Ranscog. Ranscog are doing a Queensland-style things. NHS England is doing a 26 hospital pilot and then rolling it out across England. They're interested in coming to a health sector, an entire state or an entire health provision body like Tata or any other sort of major group, and say, guys, if you're interested in this, we will come. We will do the redesign that we need, the language, provisions, etc., in order to make it workable in you. We'll do a small pilot to demonstrate it works and then help you roll it out. But we're only going to make that effort if we know we're talking to an institution which has the power and the ability to roll it on. Yes, not just for us to do all that work in one hospital in Uttar Pradesh and then it dies there afterwards. You know, it's got to be with a major health institution. So that has the power. You know, Foxy is extremely academic and good, but it doesn't have the power to roll it out across India. So we need either government, state, or a massive health provision body to be involved. And you know, I'm hoping through some contacts and, you know, like yourselves and others that I know, that we will eventually be able to tap on the door and have a conversation somewhere.
Okay. Yeah, fair enough. And
because it's free, Uma, it's free.
I know, yeah.
It's free. It's free. Perhaps if I charged a rupee, it would have made more sense because people say, oh, I'm buying something, it must be good. But because it's free, people think it can't be any good.
I have another question, sorry. Why, I might have missed it, but why is it a device and not just a computer program? What does the device do?
So there's an international definition. You know, you're used to devices like, you know, blood pressure monitor, or that's what you consider a device, oxygen saturation monitor. The international definition is that software can also be a device if it takes information, processes the information, produces new information which is clinically actionable. So this takes information, has an algorithm, it produces a new numerical factor, and then produces clinical decision support. It says, do this, do that for your woman. That makes it a software device. And certainly in Europe, it has to meet all of the very high regulatory requirements to get it CE marked. And in England, the MHRA marked. In Australia, we're going to go through their TPR or something system to get it rolled out. It's not difficult because everything in the device is externally validated, you know, robust, been shown in effectiveness studies. There's nothing experimental about it. In America, they have a slightly different approach. Their approach is if a software device produces information, it is the clinician who is the final arbiter of whether that device information is used or not. And in America, they consider these things as very low-level devices. I just have to fill out a form and give it to the FDA, and they say, yeah, you can, off you go, because the clinician decides whether they're going to act on the information provided by the software device. So in America, have a very low-tech approach, surprisingly. I don't know what the situation is in India. Do you have any idea? Is it considered a regulatory device, or is it something the clinician intervenes in? No ideas, anyone?
Uma or Ram?
India still, unfortunately, is working on AI-related or software-related tools. We don't have very clear written guidelines either in Drugs and Cosmetics Act or in the even as a guideline. Unfortunately, TDSCO, the equivalent of FDA, takes it as case-to-case basis, and there hasn't been a case posed to them yet. That's what I understand. Maybe Tav can give some inputs on from the side of the critical care side. I think there is something coming on that.
No, I agree with Ram. So the discussions are still underway that software as a medical device, and the drug regulators, and I think it's still ongoing, but I completely agree with Ram that we don't have a clear understanding yet. It's pretty ad hoc and case to case.
Well, thank you, everyone. And my plea is anyone that has good contacts with state health organizations or major health institutions that are able to work closely with the Royal RCOG and the RCM, please reach out to me. I'd love to have those conversations. They may not lead anywhere, but it's good to have those conversations and increase the brand. Perhaps one day I'll kiss the right frog and a prince will appear.
Yeah. Okay. Thank you very much, Basky and Uma and Ram online. And yeah, that was a nice end to the first week of this meeting. Yeah, so we'll call it a day here and we'll resume on Monday morning. Thanks.
See you there one day. Thank you very much, everyone. Have a good weekend.
Yeah, thanks.